In this lecture, I'm going to talk about Guillain-Barre syndrome. And as can be seen here, this disorder affects the peripheral nerves. It could be motor, peripheral nerve, sensory, or both. So the trigger or triggers for Guillain-Barre syndrome, as can be seen here, infection by Campylobacter jejuni enteritis, cytomegalovirus, Epstein-Barr virus, mycoplasma pneumonia, Haemophilus influenza or influenza, hepatitis E, Zika virus, and COVID-19. So the mechanisms involved in pathogenesis of Guillain or Guillain-Barre syndrome is that antibodies rest, or actually there is a molecular mimicry. That means similarity between some epitopes or some antigens on the wall of the Campylobacter jejuni and on the membrane. The similarity is present between the LBS on the wall of Campylobacter jejuni and the gangliosides on the outer membrane of the nerve fiber, or present here in the myelin sheath. So due to this similarity, when the immune system targets the Campylobacter jejuni, and it will produce specific antibodies. So due to this molecular mimicry, these antibodies also will come and target the gangliosides on the outer membrane of the nerve fiber. And as can be seen here, these antibodies are raised primarily against Campylobacter jejuni, but however, due to molecular mimicry or due to similarity of the epitopes on the surface of Campylobacter jejuni and the gangliosides, so these antibodies also will react with ganglioside. So these antibodies now will form immune complex when they react with gangliosides, and as you know that immune complex activate complement component number 1, and this is complement component number 1Q or C1Q. Now it will bind to the immune complex, and binding of complement component number 1 to the immune complex will activate C4 and C2, and this will lead to their cleavage, so into short fragments and big fragments. So the big fragments of C4, known as C4b, it binds to the short fragment of C2, known as C2a, and actually this molecule is known as C3 convertase. It acts on complement component number 3 and cleaves it into short fragment and the big fragment. So the big fragment is C3b. It will bind to this molecule, and this will lead to formation of C5 convertase, and this acts in C5, and then it will cleave C5 into C5a and C5b. So this will C5b will bind So no need after that to clip more complement component as the machinery is on. So C6 will bind then C7, C8, and C9. So now this is known as membrane attack complex. Maybe it will remove some phospholipid from the membrane or from the wall of the cells. But however, these three short fragments, known as anaplotoxins, they will play very crucial role in disrupting the myelin sheaths that wrapping the nerve fibers. So C4A, C3A, it will stimulate release of the histamine, and as you know that histamine release, it will lead to increased capillary permeability and vasodilatation. And C5, it will lead to influx of the cell. And the three, so now we have increased capillary permeability, vasodilatation, and influx of cell. And these are the three major events that takes place during inflammation, and this will lead to destruction of the myelin sheath or demyelination. But however, this is destructed myelin sheath as compared to the intact myelin sheath here, these Schwann cells. So now this myelin sheath get destructed, and this interfere with the impulse nerve impulse. So now let us look look at the effect of cellular immune response, and this is a distracted actually myelin sheath. This is a nerve fiber. This is the myelin sheath is not completed, is not complete. So however, I think that immune cells, they come after this injury or nerve injury, and as you know that following neuritis or inflammation of the nerve at any level, even this is at the peripheral level, but even as a central level, immune cells may come and produce inflammatory cytokines, which will make the situation more worse. So these are the cells that they come to the area, inflamed area or injured area. These are macrophages. Actually, they come, they produce, as you know, that tumor necrosis factor alpha, interleukin number 1, interleukin number 12, and these activate T helper 1, and activated T helper 1 produce interleukin number 2, and interleukin number 2 actually it activates B cell, and this will lead to more production of antibodies in situ. And also T helper 1 will produce interferon gamma, and this interferon gamma will recruit more macrophages to the area, and the recruited macrophages will produce more pro-inflammatory cytokines and makes the situation more worse than before. So let us now go or look at the symptoms. So patients with Guillain Barre syndrome may come to you with weakness and tingling in both legs. Then this may be followed by weakness and tingling in arms and upper body. So, however, this weakness may increase or can increase until the patient cannot use some muscles, as this disorder affect motor and sensory neurons. Maybe one of them, maybe both of them. However, some patients with Guillain-Barre syndrome may come with autonomic dysfunction. I may present with diarrhea, constipation, this together with this actually, and may present with urinary retention or fluctuation of blood pressure and heart rate, and acute vision loss may occur during the course of the disease. So to interfere with permanent vision loss, the condition should be diagnosed and treated as early as possible. So let us now come to the diagnosis. Actually, this is based on the clinical picture, uh, the weakness and the tingling in the upper and lower limbs may be associated with this, may be associated with loss of vision, and maybe CSF. We can take CSF by tapping, and it contains usually high protein levels, and also as a test maybe we use nerve conduction studies. However, antibodies, it is rarely they are ordered. They are ordered in some instances. For example, if it is difficult to differentiate between Guillain-Barre syndrome and other neurological disorders, and so in this situation, it is better to test for anti-gangliosides antibodies. And also, when other tests are negative, we order anti-gangliosides antibodies. So treatment, we have two types of treatment: intravenous immunoglobulin, and these are easier and maybe at home and less expensive. So and very effective. The most important is that it is very effective and it is safe. Up to 5 can be given this intravenous immuno up to 5 days. The other type of treatment is plasmapheresis, and actually it gave very similar result to intravenous immunoglobulins. So and here in this disorder, I mean Guillain-Barre syndrome, there is no room and no need for corticosteroids. So corticosteroids in Guillain-Barre syndrome are not recommended for the treatment, and we recommend treatment with intravenous immunoglobulins. And as can be seen here, intravenous immunoglobulins are given by an injection, and these antibodies they interfere with anti-gangliosides, and this will lead to antibody aggregates, and the patient will get a benefit and will and actually recover in a shorter time. Thank you very much, Professor Ahmed Bolat.